I'm Joyce O'Shaughnessy. I'm at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. The equivocal HER2 result that's kind of in a gray zone, that isn't clearly positive or negative, is one of the most common dilemmas that I face every week in my practice. And in my opinion, it's one of the dilemmas that we need to do everything we need to do to dig into that, to get the correct answer, because the utilization of anti-HER2 based therapies, such as trastuzumab and pertuzumab, which are antibodies against HER2 in the curative setting, as well as now in the curative setting, TDM1, they all improve survival. They all improve cure rates. And so we want to be giving those therapies to women whose breast cancers really are HER2 driven. Conversely, we don't want to be giving those therapies to breast cancers that are not HER2 driven, because we are then not giving other therapies that have been proven to improve the survival in women whose breast cancers are not HER2 driven. For example, we're using less doxorubicin and cyclophosphamide, otherwise known as AC, in HER2 positive breast cancer in the curative setting. We're using more docetaxel carboplatin chemotherapy, but in aggressive HER2 negative breast cancer, we know that AC can improve overall survival in some patients, and from meta-analysis done by the Oxford meta-analysis group. So we really have to get this right. We don't want to just give HER2-based therapy just in case. If the HER2 results are in the middle, well, I'll just give the anti-HER2-based therapy just in case. That actually is probably not the right thing to do, not only because we leave out the therapy that the patients really need, the chemotherapy, such as AC, but also potentially because of the law of unintended consequences. If we block HER2, HER3, for example, with trastuzumab and pertuzumab in patients with triple negative breast cancer, where HER1 EGFR is very common, and we're blocking HER2, HER3, are we in some way upregulating HER1 EGFR, for example? So we just don't know that. And so we have to be careful. And it's just so important that we get HER2 testing correct. And unfortunately, it's common that we get a result of HER2 1 or 2 plus by immunohistochemistry, by the protein staining, looking for the amount of HER2 on the outside of the breast cancer cell. 3 plus is a true positive, and that is at least 10% of cells with completely brown membrane staining all the way around that breast cancer cell. There's almost a chicken wire visualization of all the cells together looking like chicken wire, with all this dark brown stain around the outside of the cell, completely encompassing that cell in 10% or more of cells. And that is a true HER2 3 plus, and that is HER2 positive. But then we get HER2 1 and 2 plus, and so we have to turn to FISH. And FISH is actually counting basically the number of HER2 gene copies in the cell, and then normalizing that in the denominator over gene copies of centromere 17, CEP17 gene, as a normalization. And when you have true HER2 amplification, you should have 4 or more signals of the HER2 gene copy per cell, plus a ratio of the HER2 gene copies divided by the housekeeping gene, the CEP17. The ratio should be 2 or greater to be a definite HER2 FISH positive. Sometimes it comes back in the middle. For example, you'll have a HER2 ratio of 2, for example, but you won't have at least 4 HER2 gene copies per cell. You might have 3, for example, or 3.2. So you've got a discordant result. You've got an equivocal result. So you really have to have HER2 3+, or you have to have a FISH that's positive. And FISH can be definitively positive if the ratio is 2 or above, and the HER2 gene copies per cell are 4 or greater. If you don't have that with the FISH, then you go to HER2 IHC. If you're equivocal on your FISH, you make sure you have an IHC done in the same laboratory. If it comes back 3+, as I said, that is positive. If it comes back HER2 1 or 2+, you still have an equivocal result. So what do? What you do is you can have your same pathology laboratory, and they will do this, on their own because they know this. It's part of our ASCO College of American Pathology guidelines. There's a recount. There's a recount of at least 20 more cells. So the FISH is redone. And a lot of times pathologists will get several independent pathologists to recount the HER2 gene copies and the CEP17 copies and make that ratio. And also they'll sometimes redo the HER2 IHC. If it comes back as a definite answer, positive or negative, then that's fine. You have your answer. If it again comes back equivocal, that there isn't a tiebreaker based on the IHC or the FISH, then what's done is that the block, as well as the original slides from the cancer, is sent out to a reference pathology laboratory where they will do in their own lab, they will do the IHC and the FISH all over again. They'll cut new tissue and they'll do it all over again from scratch using their own IHC and FISH methodology. And almost always that will then resolve the equivocal result. And if they need to count more cells to get beyond the initial 20 cells, if they need to count 20 or more cells, they will do that to get a definitive result. So that's basically the process. In a nutshell, it's making sure if you've got an equivocal FISH that you have an IHC result. If they're both kind of equivocal, then in your pathology laboratory, more cells are counted for FISH. And if it's still equivocal, then it is sent out to an outside reference laboratory to redo from scratch IHC and FISH. So that's really the process that the College of American Pathologists and ASCO has recommended for us. With regard to the question of whether HER2 FISH is necessary for every patient, or whether HER2 IHC, which is a simpler, less expensive test to do in pathology laboratories, will suffice ever, the answer, according to the ASCO College of American Pathology guidelines, is that if you get a HER2 3+ result, where at least 10% of the cancer cells have dark brown staining all around, completely all around the outside of that tumor cell on the cytoplasmic membrane, 10% or more, that's 3+, then you don't have to do the HER2 FISH testing according to our national guidelines. So HER2 FISH only needs to be done according to the ASCO College of American Pathology guidelines if the HER2 IHC is 1+ or 2+. And so that's what I do in my own practice too, unless I get a result that is not 100% concordant in terms of the biology of the disease. For example, if a breast cancer is grade 1 or even grade 2, strongly estrogen receptor positive, and we get a Ki67, which is a proliferation marker, and it comes back as a slow growing cancer, and now it says HER2 3+, I'll scratch my head a little bit, because usually HER2 positive breast cancers are faster growing. They're more aggressive, generally speaking. So there I might get a FISH. I might get a FISH to be absolutely sure that this is a HER2-driven breast cancer, because there are some antibodies that are in use in some pathology laboratories that do overestimate the amount of HER2 protein level that is there by immunohistochemistry. So not all the antibodies that are used across the country in various laboratories are the same. And so I always do have a little index of suspicion there if not everything hangs together, that the biology doesn't all hang together, then I definitely will get HER2 fission. Honestly, if I'm just not 100% satisfied, period, that everything hangs together, that I really know the answer, I don't hesitate to send the tissue outside for an outside reference laboratory to redo the HER2 IHC in FISH.